Now I will speak about myself. So I will present you some data about the history of clindamycin primaquine combination for the treatment of pneumocystis jirovecii pneumonia. Yeah. Thank you very much. So you may see here the pneumocystis and the pneumonia it causes. My objective for today is to give some basic data on pneumocystis jirovecii and pneumonia it causes, to tell you a bit of history, results from our own and other studies, results from meta-analysis of all the studies done with clindamycin primaquine, and I have some conclusion. My conflict of interest is that all studies performed in Canada with clindamycin primaquine have been designed and conducted by myself. There is no other study. Other which are recommended but not approved. But we should not confound that something which is approved by the FDA is not that FDA did a huge study to see if it's good or not. To be approved, someone should submit the application for the approval of the drug. Okay? So what is approved is trimethoprim sulfamethoxazole. Pentamidine was approved a long time ago, and then atovaquone. What is recommended but is not approved because no one is interested to apply or has no meaning, has no money to apply to do huge studies. It's clindamycin in association with primaquine, dapsone, trimethoprim, and which is almost abandoned trimethoprim to its folic acid. There are some problems with the approved regimens. All are fungistatic. There are data in vitro and animal models showing that even after 3 weeks of treatment, you still could find pneumocystis. We've seen this in humans. We did bronchoalveolar lavages after the treatment, and also we've been able to identify pneumocystis. They need 3 to 4 days to reach the therapeutic levels in the lung. 3-4 days for CETA, for trimethoprim sulfamethoxazole, and 4 or 5 days for pentamidine. So there is almost in every patient a third of, fourth day clinical and non-related deterioration, and all the people are in a panic. The radiologist, the young physician, and so on, and they change the treatment. There are also serious adverse reactions with trimethoprim sulfa, like Stevens-Johnson syndrome, hyperkalemia, and many others. And also with pentamidine, you may have diabetes and renal insufficiency. There are frequent therapeutic failures with atovaquone. This is known. It was approved because when it was compared with sulfamethoxazole, trimethoprim, they put in the same basket the interruption of the treatment due to failure or adverse effects. Where atovaquone is very well tolerated, but had a lot of failure. While CETA was very active, but had a lot of adverse events. And so they said they are, how should I say, similar in activity, but it's not the same. In about 50% of the patient, you need salvage therapy, either because of failure or because of intolerance. Now I speak about the clindamycin primaquine, and I wanted just to speed my presentation to have time for 2 additional speakers. You may see clindamycin here and primaquine, which is a meta-aminoquinoline. The mechanism of action of clindamycin is that it inhibits protein synthesis, acting in the 50 years ribosomal subunit. While primaquine generates, but not primaquine, it's metabolite, active metabolite, which is carboxyprimaquine, generates reactive oxygen-free radicals, and also it interferes with the electron transport, a little bit like atovaquone in the mitochondria. So this is the history, and now I'll speak about the history. In 1987, the group in Indianapolis, Indiana, United States, they received a huge grant to study everything that could be useful for treating pneumocystis pneumonia. And they had all the substances there. And they've been inspired by this paper, which showed the enhancement of the curative activity of primaquine by mirikizumab, which is like a microlab. And they said, okay, I will put also primaquine alone, and primaquine is clindamycin. So they presented this at an ICAC. ICAC is not International Conference on Antimicrobial Agents and Chemotherapy. It's Inter-Science Conference, okay? It will be in September in the United States, just to not to be mixed. So they presented the poster there, almost nobody was there. And I've seen it, and I had a patient in intensive care unit. When I came back in Montreal, I said, probably I should use this because everything else was useless. So I started the treatment, and in a few days the patient improved, the radiological image improved. But he developed bilateral pneumothorax, and he was led to die. It was considered, I don't know what we have here, where to stay, probably. Yeah, so it was considered terminal AIDS. Then I started to do like an open study as a salvage therapy, and I was not able to publish it. Finally, I presented at ICAC, but not this one, in Los Angeles, and it was published in 1989. This is why I said 27 years after the first publication. When you use the first time a regimen in another condition, you don't know which doses to use. So I choose the usual doses of clindamycin, like 600 milligram 3 times a day intravenously, or by mouth orally, 450 for those patients having more than 60 kilogram, or 300 milligram 4 times a day. Do you have an announcement?
No.
No? All right. But for primaquine was a little bit different because the humans are not rats. So I didn't know. I did the transformation. They said, okay, I'll give the usual doses we use for malaria, for vivas. So instead of 14 days, I had to give it for 21 days because this was the system. However, I can tell you that people in Indianapolis show that after 72 hours of clindamycin primaquine, you are not able to find pneumocystis in the lungs of the rats, okay? While you may find after 21 days of the other treatments. So, then I said, okay, now what do you do? I was in contact with many people in the United States. They also started open-label studies. Others used clindamycin primaquine, and they did retrospective studies or prospective. The difference was that in the United States they used, just to be different, 30 milligram per day, 30 milligram days, the rest of the world. In Canada, as I told you, everything was done with 15 milligrams per day. And because other people in Germany, for example, they use clindamycin at 900 milligram 4 times a day, where we know that clindamycin is not the active drug. It's the carboxyprimaquine which is the active drug, so it just helps primaquine to act. But they use it and the results are the same. So it was a confusion in using clindamycin primaquine. And people decided to have a workshop in Florence in 1991. And consensus document was issued and published in 92, showing that you may use 15 to 30 milligram. But for the doses of clindamycin, it's very clear that you don't need huge doses. Then I said, okay, but we don't have randomized control studies. So we studied with the Americans in the same time to do some control studies. The first one was at one center. We've not been allowed to do a Canadian study. Then we started the other one, which was published 2 years after the American study. The American study, they compared 3 oral regimens, and I will present the data. Then after 1998, there are a lot of other studies in HIV negative population, but I didn't see, I've seen just some reports in HIV positive population. There are many case series, cohorts, and also some meta-analysis. Now I will try to compact all the data, not to keep you very long here. And I put on the right panel here what happened in patients with a mild form of pneumocystis calini, pneumocystis jirovecii pneumonia. CP is clindamycin primaquine, the other one is tiometropine sulfamethoxazole. And on the right panel is the patients moderately severe when the arterial blood gas is lower than 70 millimeter. The success rate was quite the same. However, if we look at this column, the incidence of adverse events was lower, statistically lower in clindamycin primaquine. Also, the use of steroid was lower. Why? Because I told you that with tiometropine sulfamethoxazole you can have the third or fourth day deterioration. Okay. However, the incidence of rash was much higher in the clindamycin primaquine. If we look at the moderately severe patients where the steroid have been used almost legally in the two cohort, there are no differences between the two treatments, except that here we had to intubate 2 patients, while here just 1. So the problem was the rash. And the problem with the double-blind studies is that you don't know if the patient is on clindamycin or tiometropine sulfamethoxazole. So the treatment was very often stopped because of the rash. But the rash with clindamycin primaquine, which is the most frequent adverse event, is previsible. It's between 9 and 11 days. It's almost in the 10th day. 9th day of the treatment in the evening, the patient could have some fever and some macular rash that could be then generalized in 3 days. It's usually mild, and most of my colleagues treated all the patients through the rash. In one of our study, in the first study, we said, okay, to reduce the incidence of rash, probably if we give diphenhydramine or Benadryl from the 5th day of therapy, we'll stop the occurrence of the rash on the 10th day. So the smart, I don't know. What happened? Benadryl didn't change the incidence of rash with clindamycin. It stayed at 50%. However, it diminished by 30% the rash with Cetra. And we know that 30% of rashes with Cetra are allergic. The steroid had some slight effect, but much less than for Cetra. And we said the active drug is carboxyprimaquine, and probably is the culprit here. Because these patients treated only with clindamycin do not have this high incidence of rash. They have 25 to 30%, while our patients here had 50%. So we said, okay, we asked ourselves, we measured the carboxyprimaquine plasma levels on the 5th day of therapy to see if we can predict it. Do they correlate with the incidence of rash? And we didn't find a significant correlation. However, the peak primaquine levels were a little bit lower, and the peak carboxyprimaquine and trough carboxyprimaquine were a little bit higher. And we interpreted this data saying carboxyprimaquine accumulates in time with multiple doses. So probably its level on the 10th day might be higher, and probably is the cause of the rash. But no other people tried to repeat this study. We asked also ourselves, carboxyprimaquine is the active drug, do the levels, plasma levels, predict the clinical outcome? And we found a correlation between peak primaquine levels and dyspnea score at day 3, when the patient usually deteriorates a little bit. And the trough carboxyprimaquine levels correlate with dyspnea also at day 3, but also with the hemoglobin level at day 7. So you say if you have high levels of trough carboxyprimaquine, you may predict the occurrence of anemia a little bit later. Now the third double-blind study randomized, there are only 3, 2 of mine, and this one in the United States. They compared 3 oral regimen. And let's take a look at the rates of therapeutic failure. You may see clindamycin primaquine in the first 7 days, it was 5.2, and in the last 15, in the last week, only 1.7. While it was a little bit higher with dapsone trimethoprim and trimethoprim sulfan. And also here between day 8 and 13 was 3.4. Finally, if you add all the therapeutic fiber in different days, you may find 6.9 for clindamycin primaquine, almost 12 for dapsone trimethoprim, and 9.4 for trimethoprim septa. They said there was not a significant difference, but I do not have the raw figures to make the calculation, because in my mind it should be a difference here. Concerning the dose-limiting toxicity, you may see that in the first 7 days it's much lower for clindamycin primaquine, but you see the incidence is higher here because of the rash. And once again, they say dose-limiting toxicity because they stopped the medication. They didn't know if it's septa or clindamycin primaquine. However, finally, if you look at the final figures, you may see that with septa you have almost 36% interruption, and you have 33% with clindamycin primaquine, and probably most of those patients could be treated without stopping the treatment. 3 years later, if I'm not mistaken, yes, for the same study, they did a quality of life assessment, and they demonstrated that there is an improvement of quality of life by 10 points, 10 or more points, which is very significant with clindamycin from day 0 to day 7. And I spoke of the open trials of the double-blind control studies, which are only 3. Now we'll speak about meta-analysis. And the first meta-analysis was done in 2001 concerning the effect of salvage therapy if the patient failed or his treatment was interrupted. What do you give after? So as salvage therapy, they had a good number of patients, almost 500. Clindamycin primaquine was efficacious in 88 to 92% of the patients, while the others, fluornithine, which now is used like a hair removal cream in India. It's okay, I can tell you a lot of stories about. Septa was only 53%, while pentamidine was useless. Because if you change because of the failure, you have to wait and the patient will deteriorate in the next 44 days until pentamidine will reach normal levels in the lung. And also, a little bit later, another group of others looked at more cases of HIV-associated PCP. And what they showed that the responses to second-line therapy, it was much, much better with clindamycin primaquine and was worse with atovaquone. They looked also at the survival after the second-line therapy. And you may see here the pentamidine, survival is better with septa, and this is clindamycin primaquine. And they look at the survival not only at the end of treatment, which is a huge difference I see, but they looked also at the difference of 30 and 60 days and even 90 days. What you see here in the upper line, there are some different medication they use, but there are only 1, 2, 3 patients. So it doesn't have to be good. Now I showed you the meta-analysis for the salvage treatment, but we did also meta-analysis when clindamycin primaquine was used as the first-line treatment. We had 715 patients included. The rate of success, failure treatment limiting adverse effects was the same. We didn't find in this meta-analysis differences. However, dapsone trimethoprim was similar to septa, but you know there are 40% cross allergy, while atovaquone was much, much less effective, and it was a huge and high relapse rate. The people also, other people, the same group presented before, they looked at the survival by first-line treatment. And you may see that pentamidine is the worst, then is sulfamethoxazole, and better is clindamycin primaquine, even after 60 days after the treatment. So the survival was better. what happened in patients HIV negative. There are not randomized studies. We cannot do the randomized studies in this kind of patients. There are case series, especially the small outbreaks, cohort retrospective assessment. Most of the studies have been done in recipients, renal transplant recipients, and even those small outbreaks. But also, it was used in patients with leukemia, systemic lupus cancer, solid organ or hematopoietic stem cell transplant recipient, rheumatologic diseases, primary immunodeficiency. So it was used, and we'll see what happened. What happened is that you have results and you have mainly opinions. But all the opinions are good, so I was very happy. So they said clindamycin and primaquine is a good alternative in patients intolerant, allergic, who fails to sulfamethoxazole. They looked at salvage or first-line treatment because in patients with hyperkalemia, you cannot give huge doses of sulfamethoxazole trimethoprim. Trimethoprim increases the hypokalemia. So it was efficacious both as salvage and first-line treatment. And now I'll conclude. I don't know if I have taken too much time. Yeah. My conclusion are only three. The efficacy and safety of this regimen was well proven in mild and mild to moderate cases in both first and second line treatments. No large trial was performed in several cases, only case series. In severe clinical forms reported good outcomes. We presented a case series of 27 patients in intensive care unit, and we had good results, but we never published. It is not approved by FDA, once again, because no company or individual wanted to apply. Both drugs are generic. And I think I will stop here. So I'll take some water, and I'm ready to answer your questions.
I have a question.
Yes.
I might miss your explanation about mode of action of clindamycin. In general, clindamycin is active against protein synthesis of prokaryote, but pneumocystis is eukaryote. Why does clindamycin and
no, I showed the mechanism of action of clindamycin in microbes, in bacteria. This is what is known. It was not studied there. So I showed what we know about the mechanism of action. But we don't know why it enhances the activity of primaquine. Yes, the other people in malaria, they didn't know why medicamycin enhances the curative activity of primaquine. So we don't know.
Okay.
So the answer is yes, no, we don't know.
Okay. And regarding the atobacom single therapy is not active against malaria. Therefore, they use the combination of atobacom and proguanil. But how about pneumocystis?
Yeah, I thought this combination is very good for pneumocystis. Okay, proguanil acts.
Proguanil.
Where acts the proguanil?
Yes, proguanil.
Yes, but where is the mechanism of action? Is on the. I think someone. I put it here somewhere. Yes. Inhibits the flow.
The hydrochloric reductase, yes.
Like trimethoprim,
yes.
yeah. So it could be a very nice combination. Yeah. They did a study just with atobacom, which let's say is 25 times more expensive than Cetra.
Oh.
And the protocol was done with 3 doses per day. Now they say they have a better formulation, is 2 times a day, 750. However, for prophylaxis, they said you should give once a day, 150 milligrams. The market is much higher in prevention. So,
thank you.
The hydrofolate reductase.
So
Other questions?
Is it possible to assume that pneumocystis has endosymbiont? sensitive to antibacterial antibiotics. So it is recently widely known that, for example, some fungi, such as rhizops, contains the
Let me think about it. Pneumocystis
I learned much
used
from
to
you
be
this morning.
in vertebrates, okay, where the blood has a temperature of more than 37. Wolbachia does not resist to more than 30 degrees,
But
so could not develop.
many other bacteria are potential symbionts.
Yes, but what I said for pneumocystis has aspartyl proteases, but I do not want to talk about. They have aspartyl proteases which could be inhibited by the protease inhibitor, HIV protease inhibitor. Could also be inhibited by proteasome ubiquitin inhibitor, bortezomib. But I will find the next conference, but not this one. I will tell you if Wolbachia could infect pneumocystis.